So I'm going to talk about preventing and detecting gynecologic cancers today. Just see if this will work. Let's see. Okay. So a disclosure is that I was previously on the Merck Speakers Bureau. So my goals for today's talk are to identify, at the end of the talk, for all of you to be able to identify signs and symptoms of gynecologic cancers that should prompt further evaluation, identify any modifiable risk factors for gynecologic cancers, and identify interventions that can reduce your risk of gynecologic cancer. So when I say modifiable risk factors, what I mean is that there are actually some gynecologic cancers where we can actually change our risks for them. So what are the 5 main gynecological cancers? So there's ovarian, cervical, vulvar, uterine, or the most common type of which is endometrial, as well as vaginal cancers. So just for the sake of time today, we're going to be talking about the 3 most common types of gynecologic cancers, which are uterine cancer. So that's going to be what develops in here, the ovarian cancer, which really we kind of lump together fallopian tube and ovarian cancer together. So we'll talk about cancers that arise in this area, and then cervical cancer. So why do we care to begin with, right? So cancer is the 2nd leading cause of death among women in the United States. So if you see that really the percentage is almost exactly the same. It's 22% is heart disease, of women in the United States die from heart disease, and 21% of women die from cancer. So I've given this talk now from, or a talk similar, or talks with this slide in it for many years now. And every couple of years it gets updated with more recent data. And when I started, heart disease was really about it stayed around, it was like about 20–25%, but cancer was much lower. It was still the 2nd leading cause of death, but it was much lower. And it's been creeping up, and they estimate that within the next 5 to 10 years, cancer will actually surpass heart disease as the #1 leading cause of death among women in the US. So let's start with uterine cancer. So this here is the uterus. This where this line is pointing to is actually something called the endometrium, or the lining of the uterus. And this sort of rougher looking stuff here is the muscle of the uterus, or something called the myometrium, if you hear that term. So just going back to this picture, most cancers of the uterus arise in this lining here, the endometrium. This is where when a woman is pregnant, the baby develops within this lining of the uterus, the placenta implants in here. If somebody's not pregnant and menstruating, this is the lining that is sensitive to hormones and builds up. And then if a woman is not pregnant, they shed that as their period. So uterine cancer is the 4th most commonly diagnosed cancer among women in the United States, with over 60,000 new cases each year, and about 12,000 deaths from uterine cancer annually. So the lifetime risk of uterine cancer is actually pretty small. It's only about 2.8%. The average age at diagnosis is 62 years. So about 75% of women are postmenopausal at the time of diagnosis. 25% of women are premenopausal. What that means is that they are still menstruating. And believe it or not, 5 to 10% of women are less than 40 years old when they are diagnosed with uterine cancer. So what are some risk factors for uterine cancer? So one of the risk factors is something called Lynch Syndrome, or the older term for it was hereditary non-polyposis colorectal cancer. That's just these are really just fancy ways of saying that it's these are genetic mutations that somebody inherits that increases their risk of certain cancers, colon cancer being one of them, but also uterine cancer being another one. And the relative risk over somebody who does not have this mutation is about 6 to 10-fold. But look at this, right? So this is something that somebody inherits, right? So just like we can't change the color of our hair, or the color of hair that we inherit, or the color of our eyes, right? People can't change whether or not they inherit a gene that leads to Lynch syndrome. But being obese, 50 pounds or more over your ideal body weight, basically gives the same kind of relative risk as though you inherited something that increased your risk of developing uterine cancer. So this is one of those modifiable or changeable risk factors for uterine cancer. Some other risk factors are if somebody just uses estrogen, but without progesterone to protect the lining of the uterus. So this was done many, many, many years ago, before we knew about this risk, when women were having hot flashes or night sweats and were postmenopausal. But we no longer do that. We give them estrogen and progesterone if they have a uterus, so as not to increase their risk of uterine cancer. I will, however, say that there is now this business out there of hormone pellets that are injected into usually they're like the size of a grain of rice, and they're implanted into the buttocks. And those really, I've seen multiple women who have developed uterine cancer or precancer, something called hyperplasia, because again, those are not really regulated. So you don't know how much hormone you're getting, or really which hormones you're getting exactly. And so there is some unopposed estrogen that can occur with those pellet usage. Tamoxifen therapy increases one's risk of uterine cancer. So in women who are receiving tamoxifen, which is a medication that's sometimes used for treatment of breast cancer, we always counsel women that if they start having any abnormal bleeding or discharge, that's something that needs to be evaluated. Now, even if you're not 50 pounds over your ideal body weight, but if you're 30 pounds over your ideal body weight, that still increases your risk of getting uterine cancer threefold. Some other risk factors are diabetes, late menopause, if you go into menopause at a later age, nulliparity, meaning that you've never had a child, that increases your risk of uterine cancer. The older you are, the more likely you are to develop uterine cancer, and that's true for most cancers. If you have a history of infertility or menstrual irregularities, or if you have high blood pressure, all of those are completely separate from being obese, that also increases your risk of uterine cancer. Some protective factors for uterine cancer are actually having been pregnant in the past. If you're over the age of 15 at your first period, obviously you can't always control those first two risk factors or protective factors, but oral contraceptives, specifically those that have progesterone in them, or even if it's not an oral contraceptive, meaning like a birth control pill, but if you have an IUD that has progesterone, so an intrauterine device such as the Mirena or Kaelblein, there's so many out there now, Liletta, Skyla, all of those are actually protective for uterine cancer. So how do women present? 90% of women with endometrial cancer will experience some type of abnormal bleeding. Remember how I said earlier that 3/4 of women are diagnosed after menopause. So most women will complain of some vaginal bleeding or spotting or a new discharge after menopause. Some women will just be menstruating for a really long time and kind of have a late menopause or really like not go into menopause. And they're like, this isn't normal. I'm like 58 years old and all of my friends have stopped bleeding. Why am I still bleeding? And they go and get checked out. If somebody is still menstruating, but they all of a sudden have the new onset of heavy menstrual periods, like this is completely different than their usual periods, that also can be a symptom of endometrial cancer. Oftentimes it is not. There are a lot more common things that cause that, such as polyps or fibroids. But again, it's just something to think about that should lead to evaluation by a gynecologist. If somebody all of a sudden develops bleeding in between periods or any type of abnormal uterine bleeding, even in women as young as 35, my youngest patient that I've cared for personally with uterine cancer was 27 at the age of diagnosis. Really just needs to be checked out. Some women will have pelvic or abdominal pain, although that's a little bit less common. And many women will say that they just have a vaginal discharge. That's not actually bleeding or spotting. But again, especially in a postmenopausal woman, that's something that needs to be evaluated. Some signs we might see, you might feel a pelvic mass. Oftentimes we don't. Oftentimes the uterus is a normal size and there's no specific mass that we see or feel. And some women will get an ultrasound done, ordered by their physician. And sometimes we can see that lining of the uterus can be thickened on that ultrasound. That again does not definitively diagnose a uterine cancer, but it just raises our suspicion. There are other things that can increase how thick that lining is, such as polyps or fibroids as well. So I just want to briefly talk about the role of obesity. So obesity is defined by your body mass index, which basically is a formula where we divide your weight, or you take your weight in kilograms and you divide that by your height in meters squared. So a normal BMI is less than 25. Somebody who's overweight has a BMI between 25 to 30, and if somebody who's obese has a BMI of over 30. Now, this is kind of a simplistic classification because there's actually different classes of obesity as well, class 1, class 2, class 3. There's other ways to characterize obese patients, but the important thing to know is that 65% of the US population is overweight or obese. At this point, almost half the US population is obese. And this is the important fact. Being overweight or obese accounts for 20% of cancer deaths, not diagnoses, cancer deaths in US women. And so why is that? Specifically for endometrial cancer or this uterine cancer, 40% of all the uterine cancers that we treat can be attributed to obesity. And the reason for that, if there's any folks who love chemistry or want to go back to their organic chemistry days, the reason why endometrial cancers can be attributed to obesity is because testosterone, which men and women have, gets converted to estrogen, something called estradiol, in the fatty tissue by an enzyme called aromatase. Now, the way that I explain this to patients is that if you see really overweight men, it looks like they have breasts, right? That's not just fatty tissue there. That's actually their testosterone getting converted to estrogen and stimulating their breasts to grow. So in women, similarly, this testosterone gets converted to estrogen. So it increases our risk of breast cancer, being obese, but also increases our risk of uterine cancer because now we have that unopposed estrogen that we talked about before, that there's no progesterone to kind of, or not enough progesterone to kind of counteract that. And so what that leads to is then something called endometrial hyperplasia, which are precancerous cells. And then if you don't treat that, the hyperplasia, or treat the obesity, well, then it can progress into uterine cancer. The other reason that's so important is because it impacts all of our treatment decisions. You might be wondering, well, what is this picture over here? Underneath all of this, there's a patient underneath there. And this is a surgical robot, something called the Da Vinci robot you may have heard of. It's something that it's a surgical tool that we use for a lot of uterine cancer stagings, particularly because this is really helpful in overweight and obese women to be able to really do the surgery through a minimally invasive approach. But I have had some patients with uterine cancer who are too obese to have surgery because they can't tolerate the positioning that's needed to undergo the surgery. Their heart or their lungs have other issues because of their obesity as well, where they are not safe to undergo general anesthesia for this surgery. Surgeries become more difficult. There's an increased risk of complications in obese patients, and that's just true of all abdominal surgery. If somebody needs radiation after surgery, there's challenges in terms of how we dose the radiation, because in order for the radiation to get to the area we need it to get to, it has to go through multiple layers of fatty tissue in an obese woman. And then there's also questions about if we needed to give chemotherapy, well, what's the optimal dose to give, particularly in obese patients? So it's, this is, I can't overstress how this is one of the modifiable risk factors for not only uterine cancer, but we know of at least 10 to 12 other cancers that are directly related to obesity. So Lynch syndrome, as we discussed a little bit earlier, confers this 10 to 12-fold increased risk of uterine cancer. It's basically this genetic defect in specific genes that help repair DNA. There's an increased risk of colorectal cancer, as well as endometrial or uterine cancer, but also other cancers. So ovarian cancer, stomach or gastric cancer, small intestinal cancers, cancers in the urinary tract, the pancreas, and even certain skin cancers. So how can you prevent endometrial cancer? By maintaining a healthy weight. So that's including like lifestyle changes, so diet and exercise, know your family history. And so we always want to offer genetic counseling for patients who have a personal or family history that are suggestive of this Lynch syndrome. There's even some data suggesting that in patients who have a BRCA1 or BRCA1 mutation, that they are at increased risk for a specific type of uterine cancer. So in those patients, we actually also offer a risk-reducing hysterectomy, meaning removing the uterus along with the fallopian tubes and ovaries to reduce their risk of cancer. And if somebody is found to have Lynch syndrome, we recommend a risk-reducing hysterectomy, meaning, again, removing the uterus, the cervix, the tubes and the ovaries when they're done childbearing or by their mid-40s, because we know that their risk of uterine cancer increases after their 40s. So some things to just take home and remember about uterine cancer: that increased body mass index, so being overweight or obese, leads to this increased estrogen production in the fatty tissue. Anybody with postmenopausal bleeding, so any bleeding, new discharge, spotting after a year of no period, always needs further evaluation. And imaging is not enough to definitively rule in or rule out uterine cancer. You always have to have some kind of a tissue biopsy, meaning either a biopsy in the office or something called a D&C, or dilation and curettage, which is a procedure that's usually performed in like an outpatient surgery center. It's a same-day procedure where we basically scrape some of the tissue from that lining of the uterus, send that to the pathologists, who are the doctors who look under the microscope and then tell us what they see. The good news about uterine cancer is that most of these cancers are diagnosed early stage and super early stage, stage 1, because women have this symptom of bleeding after menopause, and they're like, I haven't bled in over a year. That's not right. So then they go and see the doctor. So, over 75% of women with uterine cancer are actually diagnosed as stage 1, and they have excellent prognosis. There's no effective screening test for uterine cancer, so we do not recommend screening ultrasound or screening biopsies in a low-risk woman. And importantly, just know your family history. That's going to be a theme of my talk this evening, because if you have a family history that's suggestive of, for example, Lynch syndrome, well, then you may actually benefit from some screening tests or risk-reducing surgery. The other thing I just want to reiterate is that most women with endometrial cancer, again, are diagnosed stage 1, but most of them do not die of their uterine cancer. They die of heart disease and other obesity-related complications. So then I want to move on to ovarian cancer. If you look at the title of my slide, it says ovarian, fallopian tube, and primary peritoneal cancer, because these are all treated in the same way. And if you just looked under the microscope, somebody just gave you kind of a biopsy and they didn't tell you exactly where it was from, all 3 of these look the exact same and they're treated the same. So the ovaries are these, well, depending on what age you are, almond-shaped and sized hormonal organs that are attached to the uterus. And the fallopian tubes, the role of the fallopian tubes is to grasp the egg that's released by the ovary and help transport it down into the uterus to allow for sperm to then fertilize it. So ovarian cancer is actually not all that common. It's the 11th most common cancer among women in the United States. So only about 20,000 women are diagnosed with a new diagnosis each year. But it is the 5th most deadly cancer among women. So if you can recall from the uterine cancer discussion, uterine cancer was the 4th most commonly diagnosed cancer, but it was the 6th most deadly, whereas ovarian cancer, much less common, but more deadly than uterine cancer. Almost 14,000 deaths related to ovarian cancer annually. So it's the 5th leading cause of cancer death in US women. Most women, unlike in uterine cancer, where I said 75% of women are diagnosed stage 1, in ovarian cancer, 75 to 80% of women are diagnosed at advanced stages, so stage 3 or 4 cancer. And our cure rates still remain kind of discouraging with conventional surgery and chemotherapy. That's changing a bit now with more immunotherapies and actually a newer class of drugs that have really shown a lot of promise and increased patient survival. Again, just like uterine cancer, there is no effective screening test for ovarian cancer. And again, it's really not that common. 1 in 70 women will develop ovarian cancer in her lifetime. So what are some of the risk factors for ovarian cancer? So again, family history really leads to an increase in risk. Specifically, if patients have a BRCA1 or 2 mutation, again, those are genetic mutations, something you inherit from your mother or your father that increases your risk of specific cancers. For our purposes, it's really breast and ovarian cancer, but there are other cancers, and there are cancers that affect men, and that's really important to know, because I have many patients who say, oh, well, I only have sons, so they don't need to get tested. That's not true, because number one, there are cancers that affect men, and number two, they can pass it on to if they end up having daughters, and so that's important information. Even if somebody doesn't have a BRCA1 or 2 mutation, but they have a female relative with ovarian cancer, their relative risk of ovarian cancer is significantly increased. We also now know that there are actually many other genetic mutations that increase one's risk of ovarian cancer. They're too numerous to list here, but we know Lynch syndrome increases your risk. There's other mutations such as RAD50, those in the RAD51 family, BRIP1. I mention those only because those are, you might see or hear those also now in the literature or in the lay press, and just want you to be aware that those also increase your risk of ovarian cancer. Again, just like with uterine cancer, the older you are, the higher the risk. Infertility increases one's risk of ovarian cancer. Again, never having been pregnant increases one's risk of ovarian cancer. Having endometriosis increases one's risk of 2 particular types of ovarian cancer. And this is interesting. So higher socioeconomic status, even when controlled for all these other variables, increases one's risk of ovarian cancer. Early menarche, meaning getting your period early, so less than 11 years old, or going through menopause late, also increases one's risk of ovarian cancer. Now, you'll see the last 2 rows, the relative risk is less than 1. That means that these are protective, and they're not risk factors, but they protect you from the risk of ovarian cancer. So having had a prior hysterectomy, so even if you had the uterus removed, but the tubes and ovaries remain, your risk of ovarian cancer or fallopian tube cancer is decreased. If you've had a prior tubal ligation, meaning having your tubes tied in the past, that also decreases your risk of ovarian and fallopian tube cancer. And having used birth control pills in the past also decreases one's risk of ovarian cancer. So it's one of the things when we counsel patients about birth control pill usage, that it's kind of one of the pros of using it is that it decreases your risk of ovarian cancer. So in terms of presentation, so how do patients come to see me with ovarian cancer? Most times they have no symptoms in early stages. And again, that's why 75 to 80% of women are diagnosed in advanced stages, because in early stages, their symptoms are really vague, nonspecific. And in advanced stages, they remain vague and nonspecific. Sometimes patients will complain of pain. Some patients will complain of some changes in terms of how they urinate, like they might be going more frequently or feeling like they can't empty their bladder completely. Others will complain of that their belly's getting bigger. But interestingly, they'll talk, a lot of these women are postmenopausal. And so I don't know, those of you who are listening in today, how many are postmenopausal, but then what they'll do is what women will do, we'll go and talk to our friends, and then they'll say, oh yeah, after menopause, that happened to me too. I gained a little bit of weight around my belly and I couldn't get rid of it, or how I urinated changed, right? So they kind of, women, we're really good at dismissing a lot of our symptoms too. Sometimes they'll notice like a change in appetite. They'll feel full a lot faster, or they just won't have much of an appetite. Some women will notice changes in terms of like their bowels and their GI system. So they'll have nausea or vomiting or diarrhea or constipation, or alternating between the diarrhea and constipation. But there is actually an average delay in diagnosis of 6 to 12 months after the onset of symptoms. And the reason for that, again, is because a lot of these are just really vague, right? So women will maybe, kind of deal with it for a little while, then will realize it's not going away. So they'll go see their primary care doctor. Then they might send them to a GI doctor. So by the time they actually get a diagnosis, 6 to 12 months have passed since their original symptoms started. And again, most women are diagnosed with stage 3 or 4 disease. Some signs when they present, usually with the advanced disease, you might feel a pelvic mass. Many times their belly is distended because of fluid in the belly, or something called ascites. So you might feel something called a fluid wave, where we can actually shift some of that fluid around and notice that on exam. We do know that getting treatment from a gynecologic oncologist is actually an evidence-based recommendation to improve survival from ovarian cancer. So it's really important that patients see a GYN oncologist if there's a suspicion for ovarian cancer, so that they get the right surgery at their very first surgery. So just briefly to touch upon genetic mutations in ovarian cancer. Again, the vast majority of ovarian and fallopian tube cancer, 90 to 95%, are what we call sporadic, meaning we do not yet understand or know why one woman got ovarian cancer and another didn't. But there's this small slice of the pie, this 5 to 10% of women who have who developed it because of a gene or genetic mutation that they inherited that increased their risk. And we know that BRCA1 is responsible for about 70% of these 5 to 10% of women with ovarian cancer that inherited a gene. BRCA2 patients are about 20%. The Lynch Syndrome patients here are about 2%. And there's a whole bunch of other single genes that we've now identified that make up that other 8% or so of women with ovarian cancer who inherited an increased risk of developing it. So just briefly about BRCA mutations, just because these are the most commonly known and heard of in the media. So it increases one's risk of breast cancer, ovarian cancer, prostate cancer, laryngeal, so of the throat cancer, as well as pancreatic cancer. And if you look here, just at this chart really quickly, this y-axis over here, this is the cumulative ovarian cancer incidence, okay? With time, and then this over here is age. So what you can see is that this BRCA1 is in the red line. So you can see, hopefully you can see, it's kind of covered by the BRCA2, but you can see that the red line, the slope, it starts to increase here at around the age of 40. So you can see it's kind of relatively flat here, and then it goes up, and then it significantly increases after around the age of 45. So the reason why I show this is that for BRCA1 patients, we actually recommend risk-reducing surgery, so removal of the tubes and ovaries, possibly the uterus, prior to the age of 30 or prior to the age of 35, because of this increased risk after that age. In BRCA2 patients, you can see that the incidence of ovarian cancer, right, the risk of developing doesn't really increase until somebody's mid-50s. So in BRCA2 patients, we can usually counsel them that they can wait a little bit longer. So we usually counsel them closer to the age of 45 that we would recommend removal of the tubes and ovaries. And the reason for that is you really want to remove the tubes and ovaries at least 5 to 10 years before the risk increases. Because again, we're still learning a lot about ovarian and fallopian tube cancer. So we know that the cancerous cells are there prior to getting diagnosed here, right? So we just don't know how long. And so that's why we usually recommend having treatment 5 to 10 years prior. So just some ovarian cancer take-homes. Symptoms of ovarian cancer are often non-specific. So it's really important. I tell patients this all the time. You know your body best. And so if you develop changes in your bowel habits or your bladder habits that last for more than a week or two, abdominal pain, pelvic pain that's vague, and again, not going away, that's something that should be checked out. Again, there are so many other things that are not cancer that are more likely to cause those symptoms. But again, it's just something that you shouldn't just disregard and should be evaluated. There is no efficient way to screen the population. So we do not, again, recommend screening ultrasounds or screening imaging for ovarian cancers, because we know that we will actually end up finding a lot of false positives. And actually, in early stages, many ovarian cancers don't even show up on ultrasound or CAT scan or MRI. These cancers are usually diagnosed at an advanced stage. And again, know your family history, because if there's something that's suggestive of possibly one of these mutations that might increase your risk of ovarian cancer, that's something you should discuss with your physician about possibly getting genetic counseling or genetic testing. And if there is a suspicion in a woman that they might have ovarian cancer, they should be referred to a gynecologic oncologist. I will just, I get there's a lot of confusion around what I actually do or what a gynecologic oncologist is. I probably should have started the talk saying this, but because I have, I'll have people say, "Oh, you're a gynecologist." Well, not exactly, or they'll be like, "Oh, you're an oncologist." I'm like, "Well, kind of, but not the oncologist that you think that's going to, treat, give a lung cancer patient chemotherapy, for example." So gynecologic oncologists, we do 4 years of residency after medical school in obstetrics and gynecology, and then we do an additional 3 to 4 years of fellowship training in gynecologic oncology, which is where we basically do advanced and complex surgeries for women with these GYN cancers, but also give chemotherapy as well. So many GYN oncologists actually give their own chemotherapy for women with GYN cancers. So, we typically don't treat, I don't do routine pap smears. I don't deliver babies. And we don't typically treat other benign conditions like fibroids or endometriosis, unless if somebody needs more complex surgery, they may be referred to us. So we know that women with ovarian cancer have the best outcome and the best overall survival if their initial surgery is performed by a gynecologic oncologist. So that's just important to be referred if there's a suspicion. We say ovarian cancer whispers, so listen, because the symptoms are pretty vague, non-specific, again, can really be dismissed if you aren't listening to your body. And finally, so, we were talking about uterine and ovarian cancer. I kept saying there's no screening tests. So I wanted to end with cervical cancer, because this is a cancer that we can prevent. In the United States in 2019, there were an estimated 13,000 new cases and about 4,000 deaths in the US. In New Jersey, there were about 410 new cases in 2019. Most women are diagnosed around the age of 48 to 51. And this is just data from a large database. And the reason why I just show this is that in 1975, the incidence, meaning new number of new cases, was 14.8 new cases per 100,000 women. And the mortality, meaning how many women died from this cancer, was about 5.5 women per 100,000 women. So that was back in 1975. Now, if you look at 2011 data, you'll see that both the number of new cases the risk of the incidence of new cases, as well as the risk of dying, both were halved. And the reason for that is because of pap smear screening. And we're going to talk about screening tests and how we can prevent cervical cancer shortly. But the incidence and mortality so the number of new cancer cases we see and the number of women dying from cervical cancer still remains 50% higher in African-American women. So African-American women are still at this if you just looked at that subset of women, their incidence and mortality rates are still back at where the population was as a whole back in 1975. So we really need to, when we talk about, health disparities and health equity, this is, at least in GYN oncology, this is one of the areas that we're really trying to address and look into. The cervix is really just the bottom part of the uterus. It's all connected, if you can see here. But the cervix has slightly different tissue right here if you look under a microscope. And so it's sort of treated as a distinct entity. And cervical cancer is treated very differently from uterine cancer. So what are some risk factors for cervical cancer? Risk factors are early age at first sexual encounter, multiple sexual partners, having one high-risk sexual partner, a history of other sexually transmitted infections. If somebody has had vaginal or vulvar precancers or cancer, they are at increased risk for cervical cancer. Immunosuppression, meaning somebody who may be on chronic steroids or some other immunotherapies, for example, for like rheumatoid arthritis or lupus, those women are at increased risk for cervical cancer because it suppresses their immune system. Having AIDS increases your risk of cervical cancer, and smoking, which is really a very modifiable risk factor, increases one's risk of cervical cancer. And the reason for this is because all of these are risk factors for having something called HPV, or human papillomavirus infection. And we're going to get into that in just a couple of slides. Just to know the symptoms of cervical cancer, many women will present with bleeding after intercourse, or excessive discharge or abnormal bleeding, again, between periods, because most women with cervical cancer are diagnosed in their 50s, so many of them are still having periods, but most women will have no symptoms. And the reason is, so the reason why we do pap smear screening is to look for changes caused by HPV, or human papillomavirus. So the way that cervical cancer develops is that somebody gets HPV infection of the cervix, and it has to be specifically one of these high risk types of HPV. If you think about it, everybody knows about coronavirus now. So and we all know that there are various different strains of coronavirus, right? Like long before this pandemic, coronavirus was causing colds, especially among children, like, all the time. But those were less infectious strains, less virulent strains. So similarly, HPV is not just one virus, right? There's all different types of strains, and there are specific high-risk types. And so somebody has to get infected with a high-risk type of HPV, but that's not enough, right? They have to then, that HPV infection has to stick around, or they might keep getting infected by that high-risk strain. And then it has to go undetected, and then it has to progress from this persistent viral infection to pre-cancer. And then if that's still not treated or detected, then they would develop cancer after, once these precancerous cells change. From this initial high-risk infection, so that first infection with a high-risk HPV, to the development of cancer, there's an average of 15 years. This is not something that happens overnight. And again, there's many steps along the way, and this is why pap smear screening and HPV screening is so important, because we can detect women when they have either a persistent viral infection or precancer and treat that so that it never develops into cancer. So the pap smear has become a model for cancer screening. These are just some pretty pictures of what a pap smear looks like when the cytologists look under the microscope. So these are actually some normal cervical cancer cells, normal cervical cells. And this, if you see here, is an ugly, aggressive cervical cancer cell. So how can we prevent cervical cancer? How can you prevent cervical cancer? So getting age-appropriate pap smear and HPV testing. And I say age-appropriate because depending on how old somebody is and depending on what your pap smear history is really going to determine how frequently you need to get screened. And that's something that you really need to discuss with your physician, because they should hopefully have your prior screening records and can tell you when your next screening test is due. Now, I just want to put a plug in there that just because we've extended the interval for some women where they don't need pap smears every year, where they might just need a pap smear every 3 years or every 5 years, does not mean that you don't need to see your gynecologist, because you still need an annual examination, because the GYN exam is not just for pap smears. It's to actually feel to see if there's pelvic masses, to look at the skin in the vulvar area, because you can actually develop anything that you can develop on the skin anywhere else in the body can develop on the skin in the genital area as well. So it's really important that even if your pap smear is not due, that you have an annual exam. Other ways to prevent cervical cancer are to get the HPV vaccine. It's approved, or it's recommended for boys and girls, men and women from ages 9 through 26. and it's approved up through the age of 45. So in men and women ages 27 to 45, we say that it's a shared decision-making between you and your physician about whether or not the HPV vaccine is appropriate for you at that time. The vaccine is non-infectious, meaning that there is no active virus in the vaccine, and it's non-oncogenic, meaning that you cannot get cervical cancer or HPV infection from the vaccine. It's actually it's actually composed of something called virus-like particles, not the actual virus. It actually produces higher levels of antibody than if you actually got infected naturally with HPV. So these are the HPV vaccines currently licensed in the US. I put a big X over these two because they're really not manufactured any longer. Because really the 9-valent vaccine, meaning that it protects against 9 different HPV types, is the one that's being manufactured currently. There's very few contraindications. If you have a hypersensitivity or an allergic reaction to yeast or to any of the other components within the vaccine, well, then that's one of the reasons not to get it. In terms of dosage and scheduling, if somebody gets it prior to their 15th birthday, there's only 2 doses needed, and you see the schedule here. If somebody's getting it after their 15th birthday, then it's a 3-dose schedule. We also recommend 3-dose schedule for people who are immunocompromised. So if they have HIV infection or have an autoimmune disease, then we would recommend the 3-dose schedule. Again, who should not get the HPV vaccine? Really, if you've had an allergic reaction to a previous dose of the vaccine or to any of the components within it. If, just like with other vaccines, if you have a moderate or severe acute illness, so if you've got an active cold or flu-like symptoms, you should wait until you get better before you get a vaccine. And that's any vaccine, not just the HPV vaccine. It is not FDA approved in pregnant women. We recommend getting it after delivery. But if somebody gets the HPV vaccine because they didn't know they were pregnant, there's no reason to be alarmed. There's actually a whole vaccine database and no adverse pregnancy outcomes or side effects to the fetus have been reported in those women who have received it unknowingly during their first trimester of pregnancy. And we know that it works. So after the introduction of the vaccine, we saw the prevalence of having any of these 4 HPV strains, because again, the initial HPV vaccines only covered 2 or 4 strains of the HPV. We saw a decrease in girls of 64% of having one of these HPV strains. And in women age 20 to 24, we saw a 34% decrease in these most dangerous HPV strains. These are the most high-risk types. 16 and 18 lead to cervical cancer, 6 and 11 lead to genital warts. The issue is that current HPV vaccination rates are leaving a lot of people unprotected. Just like I had said, I think like my first slide where I said that I update that that gets updated every few years as new data comes out. This one does too. The good news is that the numbers are constantly improving in terms of the percentage that are getting vaccinated, but nationwide, 4 out of 10 girls who would have been eligible for the vaccine are still unvaccinated, and half of boys are unvaccinated. Closer to home in New Jersey, the good news is like 69% of girls and 51% of boys have started the series that are eligible. But you can again see that that means that still half of boys that were eligible hadn't even started the series. But in terms of those who should have completed the series, only, again, less than half of girls and about a third of boys have actually completed the series. So in terms of cervical cancer, what I'd like for you to remember is that people should really be getting the HPV vaccine, ideally before the onset of sexual activity. So ideally before they ever get a natural HPV infection. Because what I didn't mention is that 80% of American adults will have some type of HPV infection at some point in their lives. And again, that doesn't mean that 80% of women are going to develop cervical cancer or precancer or any of that. because there's so many different strains of HPV. And again, because we also screen for this, that to help prevent cervical cancer. The other important thing is age-appropriate cervical cancer screening, so getting pap smears and HPV tests as deemed appropriate by your physician, and then quit smoking. Smoking is bad for so many different reasons, but how I explain it to patients is that every cigarette you smoke, your cervix smokes 100, because what smoking does is it actually changes the chemical nature of the cervical cells, and it allows the HPV to infect those cells much easier, and also for the HPV to stick around in those cells and cause changes that lead to pre-cancer and then cancer. So quitting smoking is good for a lot of different things, but especially for cervical cancer. So, excuse me. In summary, 40% of endometrial or uterine cancers are potentially preventable because 40% are related directly to obesity. If somebody has bleeding after menopause, that really needs to be evaluated. It's important to maintain healthy lifestyle habits and a healthy weight, and talk with your doctor about genetic counseling if your family or personal history is suggestive of any of these cancer syndromes. About 5 to 10% of ovarian or fallopian tube cancers are potentially preventable because 5 to 10% are actually hereditary. Remember to keep ovarian cancer in the back of your mind if you have abdominal symptoms or pelvic symptoms or bowel or bladder symptoms that last for more than a week or two and are and stick around. Again, talk with your doctor about genetic counseling if there's a family history that might be suggestive of, for example, BRCA1 or BRCA2 or Lynch syndrome. And importantly, over 95% of cervical cancers are potentially preventable. I will tell you just in the last, so we're actually in the 9th month already. So every month this year, I have diagnosed at least 2 women with cervical cancer, the vast majority of which have been late stage cervical cancers. And I've had this run of young women, like in their 30s and like early 40s, who have had stage 3 and stage 4 cervical cancers. All of them have not had HPV or pap test screening appropriately. So it's really important to get pap smears and HPV testing, HPV vaccination if that's appropriate for your age, and smoking cessation. I will say that recently I operated on somebody with a stage 1A1. You can't get lower than that cervical cancer. And that to me is considered a success of screening programs because it's completely microscopic, and the only way it was diagnosed was because she had an abnormal pap smear. She followed up, had her biopsies, and she was diagnosed with cervical cancer. She ended up with a hysterectomy, and I don't have the final pathology back yet, but that is a curable cancer, and it would not have been found if she had not been going for her screening test. So this is not something that I just talk about and never see. What I always say is that I should not be seeing stage 3 and stage 4 cervical cancer in 21st century America. Maggie mentioned that I do a lot of work with the International GYN Cancer Society, and I am a site mentor for the Uganda Cancer Institute. So there we see a ton of HPV-related cancers, but they don't have screening as readily available as we do here. I will also just mention that New Jersey has a program, so even patients who are uninsured or underinsured can get screening for breast cancer, for cervical cancer, for colon cancer, even without insurance. So really just we're trying to eliminate any barriers to getting screening tests for cancers that are preventable. So I'm happy to take any questions.
So it looks like there is one question in the chat box.
So it says, who should get tested for BRCA1 and 2? So again, you really have to know your family history, or if there's a personal history, like if you were diagnosed with breast cancer or premenopausal, that is suggestive of, that would be a recommendation to get tested. If you have a family history of people with ovarian cancer, early breast cancers at young ages, pancreatic or prostate cancers at young ages, somebody who has a family member who's with a male breast cancer. Those are patients who we would recommend getting tested for BRCA1 and 2. And really, it's not just BRCA1 and 2. We recommend what's called a multi-gene panel because we know that there are actually a lot of other genes now beyond BRCA1 and 2 that can increase one's risk. Great question.
Any other questions?
Does HPV vaccine prevent cancer? It does, basically because it prevents you from getting HPV infection, which then prevents precancerous cells and prevents cancer. So the HPV vaccine is cancer prevention, truly, which is pretty amazing if you think about it, right? That we have vaccines for all these other infections and things, but we actually have one that prevents cancer. So I see that Lisa. So I can't really give personal medical advice. So I would recommend that you speak with your physician. What I will say is that depending on when somebody's had their genetic testing done, we usually say that you should get an updated genetic testing every 5-ish years because we just are learning about a lot more genes that can lead to increased risk of certain cancers. So if somebody's genetic testing was over 5 years ago, I do recommend repeat genetic testing.
Okay, I think that's it for questions. Thank you very much. And,
my pleasure. Thanks, everyone.
And now we're going to introduce LuAnne, who's going to talk about the services that she offers.
Hi, I'm LuAnne from Oasis Salon and Wellness Spa, and I'll just go over a few of the general services that we offer here for our cancer patients. We have a Just For You Center wig boutique here, which is a wig boutique located in North Jersey, and they operate out of the spa as well. And we do work with insurance companies for the Just For You Center wigs. When you do come to pick up your wig, if you find one here, you'll receive a set of eyebrows with your wig as well. All the consultations that we have are complimentary. There's no obligation. And so that's a great service for you if you need to have a wig. We also have post-surgical bras here in the spa. They're the basic after you have your surgery and can then go into a different bra than what they had put on you during the surgery. We provide manual lip drainage services here. And all of the services that we provide come with special protocol for those with a compromised immune system. We have massages, which we recommend to help prevent stress and help you to have relaxation. One of the programs that we have is the Daisy Makeover, and we have the Daisy Makeover every other month. And what it is, we gather together either here in the spa or in the conference room, and we do a makeover. You'll get a little makeup kit, and we'll do a makeover with it, and basically just try to help you to enhance your features. Because if you look good, you feel good. So we just try to help you to feel a little bit better on your journey. We also provide other services such as Reiki, reflexology. We do oncology massage, and the oncology massages are through Oasis Spa. However, we're also certified through Unite for Her. So if you have a Unite for Her passport, you can come here to the spa and use your passport here for massages. I just wanted to show, I am currently in the cancer suite here in the spa. And so we have different products as well. So if you are a patient of Joyce and you need to come here, we have the vaginal dilators. We do have a wide variety of wigs. And we have different types of caps and scarves that you can wear. And this is a cool one. This is, if you are a hat person and you really would like to continue to wear your hats, you can have, this is the halo, and then you can just wear it with any hat that you have. Okay, so that's just a general rundown about what we have here in Oasis Spa as far as cancer care services. And you can look on our website or just give us a call, and then we can help you to make an appointment and help you with whatever service you need. Thank you.
Okay, there is a question, LuAnne, in the chat, and
Okay.
I'll read it to you. Can you elaborate on manual lymphatic massage and how it is different from the MLD provided at our lymphedema clinic?
The different manual lymph drainage techniques are used depending upon what the surgery is that you've had. So if you have lymphedema in your arm, we wouldn't be able to treat that. But if you have had surgery and you have some swelling and your doctor recommends that you have MLD, and that basically just helps move the lymph fluid around, so it helps to reduce the swelling and better healing.
Okay, thank you. Any other questions for LuAnne? Okay, well, thank you very much.
You're welcome.
And now Maureen is going to show us some yoga.
We'll do a little bit of breath work, a meditation, and you can just stay seated. We'll just do a very little bit of chair yoga. So just things that you can do when you're sitting down, relaxing, and you don't have to lay, on a mat. You can just sit in a chair. So just gently close your eyes and take a deep breath in through your nose and exhale through the mouth. Take one more deep breath in through the nose and exhale through the mouth. And we'll begin by relaxing our toes, relaxing the soles of the feet, relaxing the ankles, relaxing the calves, relaxing the shins, relaxing the knees, relaxing the hamstrings, relaxing the thighs, relaxing the hip bones and the sits bones. Just get really comfortable into your seat. Relaxing the lower belly, relaxing the lower back, relaxing the chest, relaxing the upper back, relaxing the shoulders, relaxing the tops of the arms, relaxing the elbows, relaxing the forearms, relaxing the wrists, relaxing the palms, the fingers, and the thumbs, relaxing the throat, Relaxing the back of the neck. Relaxing the back of the head. And relaxing each of the muscles in the face, and then let your tongue just fall to the bottom of your mouth so that we're not clenching our jaw. And again, taking another nice deep breath in through the nose and exhale through the mouth. And we'll do a little bit of breath work. It's called a box breath. So we'll breathe in for 4, hold the breath for 4, exhale for 4, and then hold for 4. And we'll repeat that 5 times. So first take a nice cleansing breath in through the nose and exhale through the mouth. And we'll breathe in, 2, 3, 4, hold, 2, 3, 4, exhale, 2, 3, 4, hold, 2, 3, 4. Inhale, 2, 3, 4, hold, 2, 3, 4. Exhale, 2, 3, 4. Hold, 2, 3, 4. Inhale, 2, 3, 4. Hold, 2, 3, 4. Exhale, 2, 3, 4. Hold, 2, 3, 4. Inhale, 2, 3, 4. Hold, 2, 3, 4. Exhale, 2, 3, 4. Hold, 2, 3, 4. Inhale, 2, 3, 4. Hold, 2, 3, 4. Exhale, 2, 3, 4. Hold, 2, 3, 4. And just return to a natural breath. And if there's any tension that built up in the body, gently breathe into that space and just let it go. And we'll begin by rolling the shoulders back. Then rolling the shoulders forward. Reaching our right arm up and reaching over towards the left side, feeling a nice stretch in the right side of the body. And we'll come back to center, reaching the left arm up, reaching over towards the right side, feeling a nice stretch in the left side body. And we'll come back to center, bringing our chin down to our chest. We'll rotate in a clockwise motion, inhaling as our chin comes forward, and exhaling as our chin goes back. And the next time the chin comes forward, we'll rotate in a counterclockwise motion. Again, inhaling as the chin comes forward and exhaling as the chin goes back. And the next time the chin comes to the chest, we'll just raise our gaze. We'll take our right hand onto the left side of our head, pressing our right ear down towards our right shoulder, feeling a nice stretch in the neck on the left side. And releasing the right hand, we'll take our left hand onto the right side of our head, pressing our left ear down towards our left shoulder, feeling a nice stretch in the neck on the right side. And releasing our left hand, we'll reach both arms up towards the ceiling, bringing our right hand down onto our back, grabbing onto our right elbow, and bringing it up towards the center of our head, feeling a nice stretch in the tricep. And we'll reach both hands up, bringing our left hand down onto our back, grabbing onto our left elbow, and bringing it up towards the center of our head, feeling a nice stretch in the left tricep. And reaching both arms up, bringing both hands down to our lap. And just like we did with our neck, we're going to just lean the chest forward and we're going to rotate in a clockwise motion. Inhaling as we come forward and exhaling as we go back. And the next time we come to center, we'll rotate in a counterclockwise motion. Again, inhaling as we come forward and exhaling as we go back. Next time we come to center, we'll bring our right arm across our chest, bring our left hand behind our right elbow, pressing our right arm into the chest, feeling a nice stretch in the shoulder. And then we'll switch arms, pressing our right hand just above the left elbow, pressing our arm into our chest. We'll bring our hands to heart center, reaching our arms up towards the ceiling, keeping our palms touching as we have our hands over our head, and just leaning towards the right side, feeling a nice stretch in the left side of the body. And we'll come back to center, leaning over towards the left side, feeling a nice stretch in the right side of the body. We'll come back to center, bringing our hands through heart center. And maybe leaning our chest down towards keeping our feet flat on the ground. We have our hands on our knees. We're just going to lean our chest down towards our knees, feeling a nice stretch in the low back. And we'll slowly come back up. We'll place our right hand onto our left knee, twisting over towards our left shoulder. And our gaze will look towards that left shoulder, feeling a nice twist. And we'll come back to center, placing our left hand on our right knee, twisting open towards the right shoulder. And we'll come back to center. And again, rolling the shoulders back. And then rolling them forward. These are just a few moves that you can do while you're sitting in your chair, just to get the muscles moving just a little bit. Thank you, ladies.